The first time I was here last December, I was very nervous because it was the first time and I was the only female speaker. But I know I'm here in such a friendly and nice atmosphere and I'm not scared anymore. Thank you very much for the invitation. I love to come again. Thank you. When you gave me the topic for my speech, diabetes and osteoporosis, I thought, oh, I went to a lot of congresses, but I never heard a speech about this topic. So I checked the literature, and I wanted to show you what both diseases have in common. Might be the bulging here and the bulging here. Let us see. I love this photo. You saw it the last time, the big mechanization of man up to the next step of evolution. But we have a similar photo too for osteoporosis. I can give you the German numbers. We have nearly the same numbers for diabetes and osteoporosis. The prevalence is nearly the same. We have 8 million of Germans who have diabetes, and about 8 million who have osteoporosis. But that are only the known numbers. We have a lot of silent numbers, I'm sure. And as you know, diabetes is a worldwide epidemic. We expect about 440 million of diabetics worldwide in the year 2030. And we have an enormous increase, as you can see, in Asia, especially in Russia, China, and in the Middle East and northern part of Africa. We have to differentiate between type 1 and type 2 diabetes. Type 1 is a juvenile type, and we have only 5% who have type 1. It's due to an insulin deficiency. And type 2 diabetes, the majority of diabetics have type 2 diabetes, has an insulin resistance. The beta cells produce more insulin in the beginning, but the insulin doesn't work. And then we have this problem, the beta cells get exhausted, and in the end we have the same problem. We have a lack of insulin for burning glucose. As I told you, type 1 has its onset in childhood or younger age, and it immediately needs insulin by shots, several shots with pens, you see on the left side, up to 7 a day or more, or by an insulin pump. It is an autoimmune disease. You know, the symptoms of type 1 diabetes, we learned it in our medical books. It's thirst and polydipsia, a lot of drinking. It's polyuria, a lot of urinating. It's weight loss and fatigue. But those are symptoms you find in type 1, but in very rare cases in type 2 diabetes. You know, the HbA1c, which is an important parameter for the treatment and the diagnosis for diabetes. The HbA1c of 7, for example, means that we had an average blood glucose of 170 milligrams per deciliter or 9.5 millimoles. We can use it now for diagnosis because HbA1c of 6 or more means diabetes. Type 2 diabetes is different. We have a very strong genetic disposition, and now nearly everybody has a father or a mother or a grandfather with diabetes in our families. And it's due to, let's call it, environmental factors, fast food and lack of physical activity. And the usual age of manifestation is around 50 years. And the big problem is the weight. You know it. A lot of people are overweight. Might be, this could be a solution, but who wants to make such a deal, a hamburger against an apple? During 5 million of years, physical activity was guaranteed. But in the last 50 years, food is guaranteed, but physical activity, that's the problem. In the Stone Age, men walked 17 kilometers a day, and women who cooked and raised the children walked 9 kilometers a day. But German statistics of today, the average German walks 600 meters a day, and I think it won't be different in your country. Those of you who were here in December remember this slide. I bring it again because it had a very good impact in you. Nobody dared to use the escalator when I was around. That's why it is important. But diabetologists are not better in performance. This is a slide from the American Diabetes Congress, from the ADA, and there is only, you can see, one tough guy who takes the stairs. The other ones take the escalator. This problem starts in childhood. A lot of kids sit in front of the TV, and exercise is very important for both diseases, for diabetes and for osteoporosis. When I checked the literature, I found several articles. Osteoporosis, an underappreciated complication of diabetes, but not so many. And there was one, the North Trøndelag Health Survey from Norway, and it showed that we had a significant increase in hip fracture rates among female type 1 compared to non-diabetic females. And the next one was even more shocking. It was the Iowa Women Health Study, and those with type 1 diabetes had a 12.2-fold higher risk in hip fractures, with type 2 only 1.7 higher risk. What might be the reason for the higher risk in type 1 diabetes? As I told you, diabetes type 1 has its onset in an age in which growth of bone takes place in the younger age. And insulin-like growth factor are anabolic hormones. And we have a lack of those anabolic hormones. And this might be the reason that we have a reduced peak bone mass already in young age. And we have now very new data. They are really brand new. You can see it on the published online, just online on the 10th of February. It's the blockade of receptor activator of nuclear factor kappa B, the RANKL, so-called RANKL signaling improves hepatic insulin resistance and prevents development of diabetes mellitus. Very new, and it's a group of doctors at the University of Innsbruck, Austria, and they published this. RANKL, you know the RANKLs, we heard already today, from osteoporosis. And this group showed that we have the blocking of RANKLs reduces insulin resistance in the liver, and might be the future is that we can combine both the treatment of both diseases with one medication would be great, but let's see, might be in some years. At the same time, this group published it nearly the same time. It's a group from the University of Erlangen, Germany, but they work together. That's why. We have other reasons for more osteoporosis and more fractures in type 1 diabetes. The mineral loss. High blood glucose leads to an increased production of urine to eliminate glucose, but at the same time, we have a loss of essential minerals, calcium, magnesium, and of vitamin D. And we have the complications of diabetes, the typical ones. You remember the complication on the kidneys, the nephropathy, on the eyes, the retinopathy, of the nerves, neuropathy, and of the vessels. Let's talk about nephropathy. 30% of type 1 diabetics have nephropathy when they have a duration of diabetes of 40 years. And as you know, in nephropathy, we can have a secondary hyperparathyroidism, a horrible word, and this can cause mineral loss, and we have to give them calcium and vitamin D. But we also have a loss of proteins, and proteins are very important for our bones and for the stability. We can have neuropathy, and neuropathy can cause pain, but can be painless. As you can see on the left side, he steps on the nails, but he doesn't realize that it is harmful. And this can also cause bladders, like the one you see on the right side. He had heat on his feet, might be by hot water, but he doesn't realize it. This neuropathy can cause dizziness and can cause falls and a lot of more fractures in type 2 diabetics. We have angiopathy. The blood supply is worse in diabetics, and this can cause ulcers, as you see on the left side. And those people with large diabetic foot syndromes have to wear shoes like the one you can see here, and you can imagine those shoes are not very stable, they can fall. But on the right side, you can see a special thing. It's the Charcot foot, which is a combination of neuropathy and angiopathy. It's a local, a focal osteopenia, and those people have to be immobile. They are not allowed to walk anymore, and this immobility can cause osteoporosis. We have the retinopathy, damage of the retina or the macula, and this retinopathy leads to visual impairment and be another reason for falls and for fractures. And we have hypoglycemia, a low blood sugar below 60, and as you know, it even can cause coma, but makes you dizzy and cause fractures. And now we have the discussion about vitamin D. It's a discussion in everywhere. Vitamin D and diabetes and cardiovascular diseases, even vitamin D and cancer. There are several articles in literature about vitamin D and diabetes. And as you know, we have different kinds of vitamin D. Vitamin D2 is taken up by vegetarian food, especially mushrooms, but nobody eats so many mushrooms. And vitamin D3 by fat fish and eggs. And that's a problem in diabetics. Due to the cholesterol history, they didn't dare to eat eggs anymore because eggs were nearly forbidden. But only 10% of the vitamin D need is by food. So the other 90% of vitamin D is produced in our body by sunlight. And the UVB light, and it's very important that people get enough sunlight, but you see on the right side, due to the history of a lot of people are scared of skin cancer and don't dare to go out in the sun, or they are covered, as in your country, or we have a lot of older people who are in senior homes, are no-goes or slow-goes, and don't get outside to get enough sunlight. The preventive effects of vitamin D are important. Vitamin D deficits lead to reduced bone mineralization, myopathy, muscular deficits, especially in the proximal muscles, and the so-called waddle gait. But there is another reason. It's the therapy of diabetes. We use those, for example, for type 2 diabetes, oral antidiabetics, and glibenclamide, a senior of antidiabetic drugs, a sulfonylurea, can cause more fractures. It's about 3% more fractured than normal. And glycosomes, do you remember? We had a very, very important reports on glycosomes in the year 2007 after the ADAPT study, and it showed that glycosomes can cause more fractures, up to 9%, but it was strange. There were fractures in the humerus, hands, and feet, not the typical locations. And the other glycosome is pyoglycosone. The glycosomes act on the PPAR gamma receptor, and the animal studies showed that the PPAR gamma 2 isoform may be important for the differentiation of osteoblasts and adipocytes from a common progenitor cell. And a new medication in Germany is the so-called sodium glucose transporter 2 inhibitor, which inhibits the uptake of glucose in the tubulus of the kidney. They lose glucose up to 70 grams a day. They lose calories too, but might be they lose minerals too. We don't know. It's brand new, so we see in the next years. And bariatric surgery is another problem. Now we cure diabetic by bariatric surgery or metabolic surgery, but the patients have to get a lot of mineral, vitamin Ds, and so on in the time after surgery for the whole life. So we have other comorbidities. Dr. Ashraf will tell about in the afternoon. We have Graves' disease, which is very common in type 1 diabetes. We have celiac disease, which is common in type 1 diabetes. And in type 2 diabetes, we have often a combination of diabetes and rheumatoid arthritis and psoriasis. And a diabetic is not only diabetic, he has a lot of other comorbidities, and he needs co-medication. And there are the long list, but I think one is very important. Nearly every second patient who comes out of the hospital in Germany gets proton pump inhibitors, and proton pump inhibitors can cause osteoporosis. So when we summarize the risk factors for osteoporosis, we have a lack of physical activity. It's the same risk factor we have for diabetes. And might be he is a hunter, but he looks like a couch potato. We have a genetic disposition, and you know, when somebody is very, very lean, he is prone to osteoporosis, but we know that those two diabetics who are lean, which is very rare, have a worse outcome. In the past, we called it type 2A, but we don't have this differentiation anymore. And we diabetologists always think of the effect of the carbohydrates and the blood sugar, but we should give the patients, we should tell them that they should use calcium and vitamin D2, because we always think of the carbohydrates. And alcohol is bad for both diseases, and the lack of sun is bad for both. We need sun. They should stop smoking. It's bad for both diseases. And we should think about our diabetic treatment. Insulin is safe. Insulin doesn't cause osteoporosis. When I prepared this lecture, I took advantage, because now I always checked We checked the weight and the height and the BMI and even the waist circumference, which is really mean. But now I will put my focus also on the height. And when the height is reduced in the course of time, I have to encourage the patient to do tests as to osteoporosis, but unfortunately in Germany, the DEXA is not paid unless a patient has a fracture or has a manifest osteoporosis. I hope it's different here. And those who were here in December remember the nice discussion we had in the afternoon about coffee, and it was said I'm sponsored by Starbucks because I emphasized the preventive effect of coffee, but it always was said that coffee is bad for osteoporosis, but I think it's no longer right. So who wants to drink a cup of coffee, he should enjoy it. I'm sure those guys had no diabetes in the Stone Age. Might be they had osteoporosis, they were very slim. So to end my lecture, I want to bring you a picture from Germany. We had winter, it was very cold, and this winter we had only few days with sun. Very bad for our German bones. Thank you for your attention.